Okay, right then. Thank you.
Yes, sir. I have started recording.
Yeah.
Yeah,
Nice.
just hold on.
But there is something problem with my screen. I am seeing only some desktop version.
Yeah. Desktop only. I'm using desktop.
Hello. I can see. Okay. Okay, fine.
Sir, actually, the people who are live using mobile phone cannot record. Only the people who are live using a laptop or a desktop, I mean a computer, can record.
Yes, correct.
I think time is up. I think it's number 7:03. എങ്ങനെ വന്നു ഡ്രൈവർ ഇല്ലോ കാർ ഇവിടെ ഉണ്ടോ ആ കൊണ്ടുപോകും ലിജി ഇവിടെ
Hello.
Hello. Yeah,
hi.
can we start, Shwasmita?
Yes, sir.
Yeah, tell.
My contact is on phone, I believe. I'm trying to log in with her.
Yeah. Okay, then we will ask Dr. Shiv Kumar to take up the.
Yes, sir. Yes, sir. No problems. No problem. Yes, sir. Yeah.
So,
yes,
Mrinalini and Deepak,
sir.
please start the show.
They are ready. Yes, sir.
Yes. Good evening to one and all. It's always a very great feel and happy to be connected through an online platform amidst this pandemic. And a very warm welcome to all the great good speakers and the participants who come here to hear this webinar. And we always believe that we are going to imbibe the best from the best brains. And the topic about COVID-19 and its impact on heart today, it's very often heard and much Googled term in 2020. And we struggle always to get in right term with it. And today we are here to take the right note from the best people. And today we are in this beautiful group, and of course we are being enlightened with a lot unknown facts about COVID-19 and its effects. And before that, a brief intro about this group, Dawn of Dinosaur. And this is the brainchild of Dr. Gururaj Rao. And it's an online, it's a WhatsApp group of dentists and doctors from different specialties. And it comprises almost around 150 people across the globe with a deep desire to learn. And mostly the presentation, the concept of every presentation in this group will be a problem-based learning. And this is the fourth webinar of this kind. And also a small introduction about our Dr. Gururaj Rao. He's a living legend and an exemplary academic with an exemplary academic career. And he has done his BDS in GDC Nagpur, first batch BDS student, and MDS in GDC Bangalore. And he was also awarded the prestigious Commonwealth Senior Scholarship at Department of Oral Pathology, Dental School in London. And he was also awarded the Master of Science in Oral Pathology from University of London. And he has established oral pathology department in many dental colleges. And then he became a founder and principal of the Anand Sagar Dental College. And I can't stop enough to brief about his academic accolades, but then I have to stop. And it's a very great pleasure to be a part of this group and learn from many great scholars here. Over to Dr. Gururaj, sir.
Thank you, Mrinalini. Ladies and gentlemen, it's my proud privilege to welcome all of you on the behalf of Dawn of Dinosaurs, a closed international academic group of nearly 150 members. We are interacting for last over 3 years, and to mark this occasion, we already had several virtual meetings where we had, on this occasion. This is the fourth meeting that we are having. The concept of our study group is to learn from each other. We, with the dimensions of coming out in our field of medicine and dentistry, in respective places and have quest for learning. Our group has people from almost all over. Please mute here. We are getting a lot of sound. Okay. We are quest for learning, and people are there from far off in the world, be it Iran, Kuwait, UAE, Malaysia, India, Singapore, South Africa, USA, New Zealand, Australia, and UK and other countries. Incidentally, the COVID-19 is a hot topic for today's world. Incidentally, several lakhs of people have been killed. Incidentally, in India also, nearly 82 lakhs people are suffering, and nearly every day, about 25,000 new cases are being found. Although our recovery rate is the best in the world of 93.4%, but still we have got a lot of debacles that are taking place, including our own past president, Mr. Pranab Mukherjee, like Chetan Sharma, the cricketer, S.P. Balasubramaniam, the singer, have succumbed to such a nasty COVID lesions. Incidentally, I would also like to welcome on this regard to our great friend, Dr. M.K. Ramesh, who happens to be the chief guest today. Incidentally, I know Dr. Ramesh since a long, long time. It seems he had been my patient also at Mysore, but I can't remember, incidentally. He had been the professor of Department of Surgery at Bangalore Medical College. Incidentally, he was also the former registrar of evaluation at the Rajiv Gandhi University of Health Sciences. He also occupied the highest chair as vice chancellor. Now, today, he is at the helm of the affairs of medical education, since he has been now designated as the president of the medical Union of India, Medical Council of India. Of course, there is no medical council as at present, but it is described as the Medical Educational Council of India, of course. So may I request our chief guest, Dr. Ramesh, to give us words at this occasion for inauguration. Sir.
Thank you, sir.
Yeah.
Good evening, everybody.
Good evening.
Dr. Gururaja, as he said, actually, once he had seen my teeth in Mysore. On the reference of Dr. Murali, I had gone to him. He used to visit to one clinic in T.R.Gururaja's road. I was in Mysore at that time. He had treated me. And Murali is my classmate. So because of him, I'm talking to all of you now. And good evening, everybody, the other speakers, and all the members of Dawn of Dinosaurs. I don't know how this name has been kept. It's a nice name. And it's a very unique group and unique name. And I think I also should emulate this type of groups. When I think about this corona, it reminds me of the story where 4 blind people describe an elephant. When it first appeared in Wuhan, and later on grew up all over the world, we never knew that it would come to this stage. In fact, at that time, many theories were coming up. Some were telling that it's just being hyped up. It's like any other viral fever. Many more people die of other ailments than this corona. And even in fact, some countries like Britain, they said actually no separate management is required. Herd immunity is the best theory. Ironically, the same England has declared lockdown for 4 weeks starting from this 5th November. At that time, when it first appeared, so many theories were coming up. You know, this disease is just a 6 to 8 months old baby. In fact, when the cases were very less in India, we were gloating over the theory that we have got inherent immunity because of BCG vaccination.
Dr.
Or
Ramesh,
maybe that we are exposed.
Can you open your screen, please? It's not visible, your screen.
My screen, sir?
Yeah, it is not visible. Yeah, now it's better. That's wonderful.
Okay, I had muted it. Okay.
Thank you. Yeah.
So when it first appeared, we Indians were very happy that is not going to come to us. We thought that BCG vaccination would protect us. And we also thought that rather many people said that tropical weather, the virus cannot survive. And we are exposed to a lot of microorganisms, pollution here. So that's also has given us immunity, we believed at the time. But now At this situation, we know none of them are true. In fact, what all theories expounded at that time, many have been turned upside down. In fact, none of us have realized at that time that it could affect the lungs, it could affect the heart, it could affect the vascular system, and everything has gone wire. Forget about theories. The economy has gone wire. Nobody has thought that this can create such a havoc. In fact, World Health Organization also took such a long time to describe this as a pandemic. It's not anybody's fault actually, because nobody knew how it's going to have developed. Now suddenly we all thought we were thinking that it's subsiding because numbers are going down. In Bangalore also numbers are going down, but suddenly the apprehension has arisen that second wave might appear. That's the reason just Germany has announced lockdown, France has announced lockdown, and as I said, Britain has announced lockdown for 4 weeks from 5th November. I don't know what India is going to do because winter is setting in. So this is high time. We have to devise a methodology or management plan, because many management plans have been expounded and many have been doing quite well and many have failed. So still, as I said, it's just a 4 blind people describing an elephant. So in that respect, the forum like this will help in opening the eyes of those blind people. Maybe this should enlighten us what new ways we can look into it, how the course of action of a course of development of this corona pandemic can be dissected, analyzed, and studied for the future of the generation, because it's taken a big toll. And in this endeavor, this is a great move by Dawn of Endeavor, the Dawn of Dinosaurs, for having organized such webinar. And I hope that is going to conduct many such webinars to enlighten people. In fact, to tell you, this webinar itself is the result of this corona. Otherwise, none of would have thought that we would conduct seminars like this. It's the result of this thing. And I wish the organization all the best in the future. And I thank Dr. Gururaja and Dr. Murali for having given me this opportunity to address you. Thank you. Good day.
Thank you. Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, Dr. Ramesh.
Thank
sir,
you. Thank you.
Thank you very
for
much.
your
Thank you.
encouraging words. And
Thank
yes,
you.
over to Dr. Deepak, oral pathologist and forensic dentist, to take over the session and to introduce the speakers of the day.
Good evening, everyone here. Without much further delay or further add-on, I would like to introduce the first speaker of today, Dr. Suma Nagesh. Madam is a consultant physician at Rangadore Memorial Hospital, Bangalore, for over a decade. And she is even a participant in COVID care team and teaching the postgraduate of DNB students. Madam is graduated from Lokmanya Tilak Municipal Medical College and Sian Hospital, Bombay University in 1991. And she has done a post-graduation in MD in internal medicine from Grand Medical College and JJ Group of Hospitals, Bombay University in 1994. She has also been, she had also worked as a lecturer in neurology at St. John's Medical College, Bengaluru. She successfully completed MRCP from London. She is a trained NHS, she's trained in NHS UK for over 6 years with special training in endocrinology and healthcare for elderly people. So now, without further add-on, we would like to turn the time for our speaker, Dr. Suma Nagesh. Over to you, madam.
Just give me a moment until I share. Just give me a moment. Okay. Am I audible? Can you see my slides?
Yeah.
Yes,
We can
Good
see.
evening once again. I'm Dr. Suma
evening.
Nagesh.
Good evening.
I thought since it is IPL season going on, let me go on with COVID highlights, because that's what everyone is interested about. Today being the RCB match, I think everyone is more stressed and more worried about that. Let's go ahead. COVID-19 highlights. As we know, COVID-19 is the full form of coronavirus disease 2019. It's also known as severe acute respiratory syndrome coronavirus 2. These are the names what has been given to it. As it is SARS-CoV-2. As Dr. Ramesh just now said, that the outbreak in one city of China in December 2019 was the beginning of all problems. The next 3 months, It spread over to more than 225 countries. And in March, WHO had to declare it as a global pandemic. We all very well know that it is an airborne transmission of the respiratory droplets, which are full of virus. What I mean by super spreader is that this virus transmission is worse when it is in a confined area. As we all know, the three measures of avoiding the virus is social distancing and being in an open air. Also, virus shedding in can go along for about 8 days to a maximum of 30 days with a mean of 20 days. These are all important for us to prevent the disease, for the treatment of the disease. These are few things. I didn't want to go through every bit of this COVID-19 illness because most of us know about it, know about the symptoms. In fact, our patients themselves know about the treatment. So I will not be telling you great things about the treatment because our patients call up to say, Madam, have you given this treatment to this patient? So it's like, I'm not telling you anything different about it. Now, this graph will show you that in the incubation period, which is the first 5 days, the virus replication starts. In the next symptomatic phase, which is between 5 to 11 days, virus is at its maximum replication and virus shedding is also there. After 11 days to the next 14 days, you will see that the viral replication is there, but it is slowly coming down, which is the time when you have the early pulmonary phase. And then after 14 days to the 28th day, that is the last 2 weeks of the month, in the late pulmonary phase, the virus replication is nearly not there. So what it means to say that the severity of the illness slowly increases in the last, after the second week, third week, and the fourth week. The first 2 weeks, patient may be asymptomatic. The first 5 days incubation period, there is absolutely no symptoms, but it is the worst period because the virus shedding is going on, and that is where the chances of spreading of this infection is very much there. Symptoms, as I said, all of us know the symptoms, but this is what has been found out that in a clinic wherein they have gone through the patients who have reported to the clinic, fever was present in 98% of patients. So fever is a very common symptom, followed by cough, which is about 78%. As a fever can be either very, very mild, can be with chills. Sometimes it is described by the patient as a feverish type of feeling. And many a times the patient may forget about the fever because it may happen for a day or two and then they are totally asymptomatic, would have taken some treatment and they would have forgotten. So the history of fever sometimes may not be given by the patient. Cough is dry cough. Sputum production is very, very rare. I wouldn't say rare, not common, but cough, dry, irritating cough, throat pain is very common. Nasal stuffiness is also seen. The next symptom to follow is shortness of breath, dyspnea. Patient complains of mild shortness of breath on doing minimal activities like going to the washroom, having a bath. At this time, I would like to mention about hypoxemia, a good word which has been termed as silent hypoxemia. It is very important because patients may not complain of hypoxia at all. Patient is fine, moving around. But when the family members note down the pulse, note down the oxygen saturation, which now everyone has got the oximeter with them, they will note, they might see that the saturation is about 80 to 85%. That is, the silent hypoxemia is a very important sign which the doctors can find, and also the family members. Next following is the very, very general symptom like generalized weakness, malaise, fatigue, myalgia, all these things are about 50%. Also, the new symptom which everyone got to know and everyone were very amazed was the new loss of smell, new loss of taste, or both. So it used to so happen that somewhere they had said that they will ask the patient to sniff some fragrance, and then if they cannot smell, it's a diagnosis of COVID. So it was a very not a very right thing to do, but this is also one of the very important symptom of COVID. Other things like GI symptoms, gastrointestinal symptoms may form 50% of the symptom presenting. It can be as simple as anorexia or abdominal pain, loose motions, vomiting, nausea. And also it has been found that some patients may shed virus in the feces, which you can detect the virus in feces in about 50% of patients. Those patients may have respiratory negative for viral RNA. depending upon the respiratory or involvement, it has also, these can be classified as asymptomatic patients or mild patients. They form around 80% of the group. In these patients, the involvement of the lungs may be there, may not be there at all, or very mild pneumonia. The next 14% of patients may come as severe patient, wherein the lungs are involved more than 50% in about 24 to 48 hours. They come with hypoxia, they come with dyspnea. The next 5% cases may be critical, wherein they may have multi-organ failure, they may come in shock, they may have ARDS, and 2% of cases may be fatal. So what I feel looking at this, the percentage of symptoms and the severities, most of the patients are asymptomatic and mild, which is a good thing. And if the patients come to the for medical aid in time, we can avoid the critical nature, severe nature. Though fatal 2%, I think it is very difficult to get it down, because those patients who are have gone through fatality may be the ones who had underlying comorbid conditions. The risk factors, regardless of age, which can turn to severe COVID-19, all of us know, because it has been propagated, advertised, that patients who have got underlying comorbid conditions like kidney disease, who are on regular hemodialysis, patients who have got respiratory problems like COPD, immunocompromised patients who have got solid organ transplant, severe heart conditions like ischemic heart disease, heart failures, who have had any coronary artery disease, who have undergone bypass, diabetes mellitus, maybe type 1, type 2, both have got equal risk factors. Any hematological disorders, maybe sickle cell anemia, anything for that matter, they have high risk for severe COVID-19. These are the underlying conditions which can predispose them to a severe COVID-19. Asthma can be either moderate or severe, CVA, cystic fibrosis, pulmonary fibrosis, because these patients are already have a lung which is compromised. So on top of it, if they have another viral infection affecting the lungs, it can turn to a severe COVID-19. Compromised immunity can be either, it can be HIV, any steroid, patients been on steroid for other illness for a long time, this or any blood malignancy, all these things can compromise their immunity and increase their risk for severe COVID. Neurological conditions, I think dementia is one of the common thing, because managing patients with dementia will be difficult to tell them to restrain themselves from all the from patients or people who have got who are high risk of transmitting the disease. That is one of the common neurological condition. Liver disease, alcoholic disease, hepatitis, all those things can be make them prone to severe COVID. Pregnancy itself, smoking, because the lung is compromised, and other hematological disorders like thalassemia, etc.
वाढदिवस दिवस मला घरी बोलवलं मी सांगितलं कॉलेजला
About COVID was that the risk or the mortality is more in mute. Hello, can you hear me? Yeah. Males, older patients, frail patients, lower socioeconomic status, those patients have higher risk for mortality.
I request all the other participants to mute.
Please mute.
नॉर्मल परीक्षेची झाली एमएचएसची
I request all the other participants other than the speakers to mute yourselves, please.
मग माझं तेव्हाच सुरू झालं म्हणे तुझा अभ्यास कसा आहे फार वेळ वाया नाही घालवायचा
सुनील तो म्यूट करो सुनील just mute your voice. Okay, madam.
Thank you. Blood group A predisposes to or puts them at a higher risk for a severe COVID infection, and blood group O has been found to be protective. Now, how do we diagnose a patient who has got clinical suspicion for COVID-19? The gold standard test is RT-PCR, that is reverse transcriptase real-time polymerase chain reaction. It is a goal-sensitive, in sensitivity test, which has been now accepted, and also the report is available within 24 hours. Then you have rapid antigen test, which is quicker, around 15 minutes. The test result is available. This is better, or this is good in a patient who has person who has got no symptom, but a person whom you feel that the clinical suspicion of COVID-19 is high. Rapid antigen test negative should be confirmed with the RT-PCR test. Going forward, antibodies, IgM, IgG antibodies, detection of these antibodies can also give us a clue about the recent infection of the COVID-19. Other tests which we normally do when a patient gets admitted is complete blood count to see whether there is any other infection in terms of bacterial infection, whether there is neutrophil count which is high, whether the lymphocyte count is low. The ratio will give us a clue as to how things are going. Liver function test, because liver enzymes are raised. Renal function test to know about the creatinine values, electrolyte values. Then coming to the specific test in COVID-19 is the inflammatory markers. We have D-dimer, CRP, ferritin. Since COVID-19 increases the thrombotic susceptibility of a patient infected, these values will help us to know whether how much is the severity of infection and the treatment modality to be given to the patients. We go ahead with the chest X-ray, very common because it affects the lungs. Chest X-ray will show hazy picture, infiltrates, haziness bilaterally, both the sides of the X-ray. ECG should be done because patients who have got underlying heart disease will show, if they show any changes, the treatment modality will change again. Echocardiogram to know how is the heart function, whether the COVID-19 is affecting the heart. HRCT chest, that is high resolution CT chest, very important test in COVID-19 because it gives us an indicator of how much the lung is involved. There are scores of the CT chest radiological scores, which tells us whether this patient will need oxygen, whether this patient will be safe enough to go home, or the patient will require home oxygen. It gives us a very good clue. Along with the CT chest, and if the RT-PCR comes negative, many times it does come negative for many reasons, but the HRCT test is positive, indicating that it is an infection. We tend to believe that the patient is a potential severe infection, and we treat the patient as if he is a COVID-19 patient. The serum IL-6 levels are the ones which are a specific test in this COVID-19. It is usually increased when the cytokine storm is present. This also tells us whether the patient will prognosticate also the patient's outcome. And depending upon the serum IL-6 levels, we will try and introduce the specific treatment, whether they require IL-6 antibodies, all those things in respect to the IL-6 levels. I've written as venous Doppler because sometimes patient may present with pulmonary embolism, or they have bilateral venous thrombosis. This is because they are it's a thrombotic state, COVID-19 in this thrombotic stage, and we want to rule out pulmonary embolism. If a patient suddenly becomes breathless, who was doing fine, suddenly becomes breathless, then we keep in mind the diagnosis of pulmonary embolism because the treatment will be totally different. Coming to the complications, pneumonia, viral pneumonitis. Pneumonia is the only thing which I will say, because that is the one thing which will lead to the severity of the illness. Hypoxia, how bad is the hypoxia, that correlates with the severity of pneumonia. It may start just as viral pneumonitis and proceed on to pneumonia involving both the lungs, and may involve, on top of it, there may be bacterial infections also. Renal impairment is commonly seen. They may have acute kidney injuries, liver enzymes, hepatitis. Sometimes few patients, they have found thyrotoxicosis also, because there has been a suppression of the thyroid hormone, thyroid stimulating hormones, and there is an increase in the thyroid hormones. ARDS, that is acute respiratory distress syndrome, is very commonly seen. That is the main hallmark of severity of COVID infection, and that tells us how severe or what is the modality of treatment of these patients. the deep vein thrombosis, pulmonary embolism, CVA, multi-organ failure, septic shock is one of the other ways wherein we may have a patient going on to a very severe COVID-19 infection. Cardiac arrhythmias are also there. Some patients may suddenly succumb who are doing fine, have been planning to discharge them home, and they suddenly collapse and have sudden cardiac death. So these are all common surprises of COVID-19 infection which we see. Neurologically, we have seen few patients coming with encephalitis, confusion, and sometimes it is difficult to say whether the encephalitis is a part of COVID infection or because they were basically having some problems with neurology and they have gone into COVID infection. Treatment, I have written treatment supportive in green, and I would highlight supportive treatment because all patients, it has till today, we have been debating on the treatment of COVID-19, but supportive treatment remains the mainstay. Earlier, we support the patient with hydration, antipyretic, giving them zinc supplements, vitamin C, vitamin D, all a big cocktail of vitamins. The better we are, better for the patient. If inflammatory markers are high, that is the time when we introduce low molecular weight heparin, because we would want to prevent microthrombi, pulmonary embolism, and we would want the patients to be free of those things because that may be a fatal outcome. Antibiotics are given to the patient because sometimes bacterial superinfections are also seen. The next step is if the saturation is dropping, that is the time when we have to start working. All this supportive treatment can be given when the patient is at home, is in home quarantine. We can continue with the thing. The minute the inflammatory markers are high, we have to be alert of getting the patient to the hospital because the next event of dropping saturation can start. Oxygen is the mainstay of treatment in patients who have dropping saturation. Steroids as one of the more major anti-inflammatory. Antiviral drugs, a big debate, big confusion, when to start, which one to start. There's so many. HCQS was on the market, was put on first, and then came ivermectin, favipiravir, and then remdesivir. All those have had too many trials going on. None of them shows much benefit, but it has been given judiciously to be used by the treating physician regarding which patient needs those treatment. So an antivirus has to be used within the first 10 days of infection. Later on, it is of not much use. I've written about prone ventilation because when saturation is dropping, prone ventilation, that is making the patient sleep on his tummy, works very well to increase the saturation, and it's a very safe and effective way, which has been sort of a breakthrough in COVID-19 treatment. Plasma therapy, IL-6 inhibitors, very off late. Too much debate, too much discussion going on about plasma therapy. Many trials have not shown much benefit from plasma therapy. Many loopholes. They found that the plasma therapy, what plasma is being given to the patient, we have not measured the antibodies in that. Probably that's the reason it has not worked. Or also maybe the patient already had antibodies within themselves, so therefore it was not working. I'm sorry, I've lost one minute. Screen sharing. Okay. Therefore, these two IL-6 inhibitors also are the ones which are big debate. We use it only judiciously in very selected patients, not much benefits. Oxygen, we use nasal prongs. I'll just go through the types of oxygen the way we use. Nasal cannula, nasal prongs, very common. We use, which the flow rate of oxygen will be around 2 to 6 liters. Very easy for the patient. Patient can eat, drink, walk around, no issues. Next is oxygen face mask with a big mask. About 6 to 10 liters can be given to the patient. The only thing is patient starts feeling a bit claustrophobic with this mask. So, but this will be, as long as saturation is maintained, these two are good enough for the patient. Next is NRBM, which has come up during the COVID-19 treatment. It's a non-rebreathing mask, works very well. 15 liters of oxygen can increase saturation to 100%, and it has done good wonders to our patients who are hypoxic. Next is high flow nasal oxygen. All these years, high flow nasal oxygens were not used at all because it was used only in tertiary centers. But since the pandemic, every hospital has been keeping the high flow nasal oxygen cannulas, the system, the equipment with them, because it is very useful to the patient. The patient is comfortable, does not feel claustrophobic. Prone ventilation can also be continued with HFNC. Then is non-invasive ventilation, wherein we are not doing any invasive type of ventilation. This works also very well to the patient. We try and alternate between NIB or HFNC or NRBM to maintain the oxygen levels in a patient. So therefore, all these modalities of oxygen therapy is done to reduce intubation chances and also to reduce mortality. If oxygen is given at the right time, in the right way, with the right equipment, we have been able to prevent intubation in many of our patients. Finally, ventilator, if there is no other choice, patient is not able to get his oxygen level to the required, then there is no other choice but to intubate the patient and put him on a ventilator. They say the right time for intubation is very important, which again has to be decided by the treating physician. Just the disease course, as you can see, the viral phase in the first few days, followed by the early infection, followed by pulmonary phase, hyperinflammatory phase. The oxygen is the main treatment of all these second two phases. So whatever treatment, antiviral, whatever supportive treatment, oxygen forms a very important pharmacotherapy treatment or a very basic drug. We should treat it as a drug in COVID-19. Look, we should treat the patients of COVID-19 in a holistic way, because they do require lung rehabilitation after they get discharged. Some patients go on home oxygen. They may continue for 2 to 3 weeks. They also go on home steroids and also oral anticoagulation. Breathing exercise, very common. We have to teach them proper breathing exercise, maybe deep breathing exercise, maybe yoga way. That is not the issue, but they should continue deep breathing exercises. Sometimes we advocate incentive spirometry, which gives them a proper way of assessing their own respiratory status. Nutritional care is very important. Most of the patients in the 2, 3 weeks of illness would have lost a lot of weight because they are anorexic, not eating well. So nutritional care, we have to emphasize to the patient and their family. Encourage mobilization, because once they go home, they think that they have to sit in one place, not move around. But we have to emphasize there that they have to carry on with their mobilization, physical activities to prevent any form of thrombosis. Follow-up in a post-COVID clinic is very important, so that we keep an eye on our patients, whether they need any further alteration in their treatment, they need oxygen. And after a few weeks, when things are settling down, a pulmonary function test to find out what is the residual damage to the lungs. We do advocate HRCT test as a follow-up, but not for all patients, only for those patients whom we feel that they are not improving as we expected. Psychosocial support to the patient and family. This may seem a very, very negligent thing, but mental health problems is a major issue in patients affected with COVID-19. It has been seen that they may have anxiety, may be depressed, simple things like sleep disturbances, drug overdose, alcoholism. So we need to give a good social support to the patient and family, and refer them to the specialist if required. We know that this pandemic can come to an end only when there is a herd immunity, and herd immunity can be in 2 ways. Either all of us get infected or we have vaccines. The vaccines, the vaccines which are really 100% efficacious and safe, that is what we all are waiting. But at the moment, status India vaccines, we have Covaxin, which is an indigenous product, and it is now developed by Bharat Biotech in association with ICMR. The virus was isolated by National Institute of Virology, Pune. About 1,000 volunteers in Belgavi district are going to be in the phase 3 trial, beginning, I think, by mid of next year. We're going to be seeing the results. 60% efficacious is what is being told about this vaccine. But since it is an emergency state, it has been allowed because it has to be 100%. The vaccine has to be 100% effective. But 60% efficacious also is been accepted this time because of the situation. The other 2 vaccines have been developed by the other companies. but the Covaxin is the one which is going into phase 3 trial. Waiting for the vaccine, yes, we are all very hopeful, waiting when the vaccine will come around and when we will be without a mask going around as we were in our pre-COVID area. But let's not forget that the vaccine may not be 100% effective. We still have to continue with the vaccine which we already have, the mask, frequent sanitization, social physical distancing, avoiding crowded places so that we don't infect and do not again bring up another burst of infection. These are the simple things which we can emphasize on ourselves, preach our patients, preach our family members, and also tell our community at large to prevent further infection. So for everyone's health and safety, let's practice using the face mask, keep a social distance, and use sanitizers. Thank you very much.
Thank you, ma'am, for brilliantly briefing up the diagnosis as well as discussing the management. We'll go ahead with taking up some questions at the end of all the talks. If any audience have any questions or doubts, they can they can type their questions in the chat box. Moving on to our next speaker. Hello.
Yeah, you can talk, Deepak. Yeah, go ahead.
Moving on to our next speaker, Dr. Shivakumar Mariappa. Sir is a promoter and director and CEO of SR Medical College and Sankara Dental College, Kerala. He is also a founder of United Global Health and SK Enterprises. Sir is a graduate of Sir has done his graduation of MBBS from Karnataka University, MS from Nagpur University. He's done his MCH from Ahmedabad. He's also a fellow in heart failure surgery and transplant from Mayo Clinic in 2006 and 7. He was also a consultant to St. Thomas and Guy's Hospital, London in 2007 and 8. He's also been speaker at various national and international forums. Most importantly, he's an health advisor to our Honorable PM, Government of India and Nepal. He's also for the Honorable CM, West Bengal, Andhra Pradesh, and Maharashtra. Without much delay, Dr. Shivakumar sir, you can take over the.
Yeah, can I make a video to be visible?
Yes.
Yeah. Hi. Good evening, everyone. So, see, today I'm talking mainly on the cardiac aspect of the COVID infection. We all know that previous speaker has briefed about COVID, how it's taking care and management and all. See how the COVID is going to affect. The COVID is mainly affecting the lungs. The lungs, when it affect, we are failure in the gas exchange. So the carbon dioxide and oxygen, the exchange will get failed. How it get failed? The SARS virus of the S spikes, it is binds with the ACE receptors as an entry point. The ACE receptors are available in pneumocytes and endothelial cells. There are two types of cells will be there. When it got infected, there is a failure in the gas exchange. So since there is an inflammatory reaction is going to happen in the lung, so there is a high level of cytokine get increased. It and results of multiple end organs getting, like it is going to get a damage in the cardiac cells. Myocardial cells is one of the most susceptible for oxygen deficiency or insufficiency of the COVID infections. When there is a patient affected with those who are underlying a cardiac disease, there is a compromise with respiratory and cardiorespiratory compromise. Those who are already having a cardiac disease or a cardiopulmonary disease, when they get affected with the COVID infection, so most of the time the myocardial cell will get lack of oxygen, which is going to increase, a respiratory distress syndrome, which can, going to be increase more myocardial damages. So when the more myocardial damage will happen, it's going to lead to an acute coronary syndrome. So there are possibilities of other cardiac, other than the COVID thing, there are other possibilities of damaging the heart is during the treatment of the COVID. So since it's across the world, globally, everything is on the trial. So there is a use of medicinal side effects like a corticosteroid, antiviral medicines, immunoglobulin agents, and electrolyte imbalance because of the renal failure. These are all going to lead more systemic illness. It's going to lead going to affect cardiac damages. So when the patient is in the ICU or in the non-ICU, how one can diagnose the patient is affected with the cardiac issues. I mean, I can say myocarditis, corona is affected to the heart. Though few parameters one has to check in those who are working in critical care units or general physicians is mainly anemia. There is a progressive increase in anemia, and there is a lymphopenia and severe hypoxemia and abnormal or an altered, I'm not using altered, abnormal liver and kidney functions, and elevated kinase and elevated D-dimers and thrombocytopenia and increased lactate dehydrogenase. And second thing, there is an increase in troponin and brine nitriuretic peptides. This is a very, very good marker to assess whether heart is involved or not. And previously, they thought, yes, fine, this is a thing. And when you done the chest X-ray, normally we get cardiac myopathies. When you find a cardiomegaly, when it's around cardiomyopathy, when you find a cardiomegaly in a COVID patient, first thing what you have to do is you should do transesophageal echocardiogram to assess the chambers of the heart, mainly right side of the heart, and pulmonary pressures. These two are very, very important before patient is going to end with a critical stage. So then you should assess the arrhythmias, ECG pattern, and other diagnosis has to be correlated with the renal functions and all. And many of the patient is going to be sick once the cardiac involvement is there, mainly on the renal failures. And another most important aspect of those who are suffering or already underlying the cardiac disease is treatment modalities has to be changed. See, everyone is blindly putting up azithromycin and HCQ and so many medications, blindly they're putting up. See, we are all aware azithromycin itself is macrolide. It is going to prolong QT. Everyone knows about it. Once you add azithromycin along with HCQ, it is going to become a worse. It is going to become a catalyst for both the drugs, and it is going to sometimes many of the patients in US and UK has lost because complete heart block, AV block, and chloroquine using a long time is going to cause an AV block. Those who are treating in ICU or a general practitioner should be very much concentrate on putting up a drug. Those who are having a cardiac disease, they should be, think of other alternative drugs other than azithromycin and chloroquine combination. They should think. And most importantly, many a time the patient comes with a pulmonary failures in the ICU. I get a lot of patients call from the different part of the world and different part of the country. They're asking, sir, can we give a prednisolone as a precautionary or as a thing? I say no. Those who are having cardiac disease, underlying disease, kindly avoid prednisolone because it's going to cause electrolyte imbalance and hypertension, and it's going to create a lot of other issues unless there is a proof that the patient is having a myocarditis. And there are a lot of debates across the world, HRCT and the CT scan and all. I still not convinced about taking a CT scan, because most of the time any pulmonary infection, it is going to show as an bilateral haziness and downglance appearance. Instead of that, we can go as an transesophageal echocardiogram and followed by MRI heart or MRI thing. If we can able to assess myocarditis and other deadly diseases things. And once you confirm the patient is infected with already patient is infected, it is going to be like a heart is get involved. Once the heart is involved, so the question comes, complication already complicated. What is the mortality and morbidity? How we can assess? So number one is a myocarditis, as I told you before. When the patient having a myocarditis is there, there's a high mortality. So 30% of the patients will not come out, those who are having a myocarditis. So there we can treat with methylprednisolone. Another one is heart failure. The patient who is already having a heart disease. So those who are working in intensive care, every day, kindly do echocardiogram. If possible, go for a T to assess right side of the heart, all the chambers, and to assess the pulmonary pressure. Why? Because when the right side heart gets failure, secondary to the pulmonary hypertension, it's going to lead ARDS and hypoxia. So, it's going to damage more heart in a day by day. So the patient end up with the ECMO. Everyone heard about ECMO. Why the ECMOs are needed? The ECMOs are needed when the patient is the right side heart failure. And another one is arrhythmias, is another deadly complications of coronary infected heart patients. So it may be due to drug induced, or it may be due to cardiac injuries and a different other either like hypoxia or so many multiple reasons. One should take care of the arrhythmias when the patient is having underlying cardiac disease with the COVID infections. So in general, I would like to conclude, because already the madam has briefed a lot about how to treat, and I'm not talking about treatment about aspect of the general treatment of COVID thing. So the patient who is already having a cardiopulmonary, underlying disease with affected with the COVID, the medication and management has to be very, very choosy, and you should be very careful. And patient pre-planned surgeries can be done in a routine manner, because since you should treat like one or the other diseases. And uh, those who are practicing thoracotomy and thoracoscopy and TAVI to be avoided. This has been published in Mayo Clinic last a month. We had discussed in a couple of guys in Mayo Clinic, Nebraska and all. So TAVI, thoracoscopic surgeries, and other minimally invasive through thorax has to be avoided. Thank you very much for giving an opportunity. I think some of the things Dr. Murali will speak, because he's a vascular surgeon. But still, I would like to underline Dr. Murali. But we both of us share the same platform. But COVID patient with the D dimer is directly proportional to the mortality. If the D dimer is high, gone. That's it. Thank you very much, everyone. Thank you, Dr. Gururaja Rao, and thank you, everyone.
Thank you so much, sir, for your valuable time, sir. It was indeed an enlightenment on impact of COVID on cardiac health. Any questions on this topic, kindly type in the chat box, which will be taken up at the end of the session. Thank you for your time, sir.
Thank you very much.
Without much delay, the next add-on is our next speaker for the day is Dr. R. Muralidhar. Sir is a graduate of Mysore Medical College and his post-graduation from Bangalore University in general surgery. He is a gold medalist and is also a postdoctoral. He has undergone a postdoctoral course in vascular surgery from Sri Chitra Tirunal Institute from Trivandrum. He has obtained his fellowship in vascular and endovascular surgery from prestigious St. Mary's Hospital, London in 2002. He is also a fellow of Vascular Society of India. He is presently working as a consultant at vascular and as a vascular and endovascular surgeon, and is also a medical director at Jupiter Hospital and Institute of Vascular Surgery, Bangalore, India. He is also a chairman of Jupiter Institutions, Nelmangala, Bengaluru, which was established in 2004. He is also a managing trustee for several institutes for social cause. In past, he has held a very prestigious positions like faculty member in Department of Surgery at Ambedkar Medical College. He's also established a Department of Vascular Surgery in the same college in 1994, and is established Jupiter Hospital and Institute of Vascular Surgery in Bangalore in 1997. Was also a consultant vascular surgeon at various other hospitals in Bengaluru. He is an honorable professor of vascular surgery at Sri Devaraja's Medical College, Kolar from 2000 to 2004. Sir is also a good standing member at various societies like member of Association of Surgeons of Indian and Bangalore Surgical Society. He is a founder member of Vascular Society of India. He is a past honorary secretary and president of Surgical Society of Bangalore. He is also an honorary member of European Society for Vascular Surgery, executive committee member of Private Hospitals and Nursing Homes Associations, Bengaluru. He's authored several papers at international and national peer-reviewed journals. He's authored many books. His main area of interest being diabetics. He's written articles in the books published in Microlabs Limited every year on diabetes and released during the annual conference of physicians of India, which is a very popular among physicians and medical practitioners and distributed throughout the country. More than 50,000 copies are printed and distributed every year. He's also been actively involved for social cause along with BJP Medical Wing. Notably, he was pioneer in collecting and contributing to nearly 2,000 crores for the Nepali citizens affected during the earthquake 5 years ago. He's also been working with BJP Medical Wing in present crisis time for COVID-19 pandemic. So, sir is also the state commissioner for the BJP Medical Wing and is working for the upliftment of the healthcare in the society. So, over to you, sir.
Thank you very much. Thank you. Thank you for that elaborate and extensive introduction. Really grateful to everyone. I hope my screen is visible. I hope my screen is visible.
Yes, sir.
Yes, sir. Okay. So I'll just, at the outset, I must thank the team of Dawn of Dinosaurs, Dr. Gururaja Rao and the entire team, for giving or setting up this forum and also for organizing such webinars. I'm really happy that they are doing well and hopefully they continue to do it in future also. And I also thank all the co-speakers, and also I thank my good friend, Dr. M.K. Ramesh. He was my classmate, and now he's occupied the prestigious post of President of National Medical Commission of the PG Studies. So without wasting much time, I hope all of you are able to see my screen.
Yes, sir.
Yeah, thank you very much. So a lot has been told about the COVID-19 infection and its manifestations in the respiratory system. But now today's topic being the COVID-19 and its impact on the heart. So we should concentrate on this because initially we need not concentrate on the cardiovascular manifestations in COVID. Now of late, a lot has been a lot of research has been done on this topic, and it's going to cause a lot of morbidity and mortality, and hence we have to know more in detail about the effect of COVID on the heart. Okay, I'll just brush through a lot of these initial slides because my previous speakers have touched upon all these aspects. It's a highly contagious disease, the SARS-CoV virus 2. And the first case was reported on the 8th December in Wuhan, in China. And the WHO declared the disease as a pandemic on 11th March. And I will review all the cardiovascular and mostly the vascular manifestations, because my friend Dr. Shivkumar has already touched upon a lot of cardiac aspects in COVID. Okay, now just to give you a timeline here, you can see in 2019, December 8th was the day when the first patient developed symptoms in Wuhan. In December 31st, China informed the WHO about the cases, growing cases of pneumonia in its country. And then by January 1st, Wuhan wholesale markets had been shut down. And as you came across, like in January end, the death toll was increasing and it spread to other countries other than China. So now we know that it all started with the bat having the coronavirus. And then there are 7 different strains which were generally causing mild infection. But there are 3 strains, the SARS-CoV-1, MERS, and the SARS-CoV-2, which caused lethal respiratory infections. Now, this is the table. You can see the third column where there is COVID-19. This is the virus, the SARS-CoV-2. And the basic reproductive number of this virus was 2 to 2.5, meaning it will spread to minimum 2 or 2.5 people during the infection. The case fatality rate, that is the number of persons who die among the infected patients, was about 3.4%. Now it has come down. It has come down below 2%. It's a good sign. The incubation period being 2 weeks, 4 days to 2 weeks. Okay. Now there are many informations like how many annual infected patients which are not available because the studies are still going on. Now this is the natural structure of the coronavirus. Everyone knows about it. It has an envelope protein, which is the surrounding protein, and inside is the nucleocapsid protein. And inside the nucleocapsid protein is the RNA, which multiplies, and hence the disease spreads in the host cells. And the one important aspect here being the spike protein, which is the S protein. Otherwise, it looks like a crown, and that is how the name is given as corona. Okay. Now, how it spreads, we all know it spreads by droplet, direct and indirect contact, or even possibly by airborne. There is a high abundance in the infected people, 1 billion RNA copies in ml of sputum. It remains stable for 3 hours in air, up to 24 hours on a cardboard, and up to 3 days on a plastic or a stainless steel surface. So in the early stages of the epidemic in China, they have made an estimate, and the reproductive number being 2.38. There are 4 major steps which are involved in the pathogenesis. The coronavirus entry and its replication, we should know how the antigen presents. And there are humoral and cellular response of the body to this infection. And that's how the cytokine storm happens. And this is just a symbolic or a pictorial representation where you can see the coronavirus, which enters into the host cell using the ACE2 receptors, which is very important, which has gained a lot of importance in these days. As Dr. Shivkumar mentioned, ACE2 receptors are used as the entry points into the host cells. So the entry of virus into the host is through these, and there is an activation of macrophages and then monocytes, which cause the cytokine storm. And by this, there are a lot of markers which are increased in the blood, like IL-10, IL-6, TNF-alpha, and ferritin. And among these, the IL-6 is very important, which is always estimated to know whether there is any cytokine storm in the patient. Now, there are so many factors which have already been enumerated by my previous speakers, like the genetic factors, the elderly people, the males are more susceptible, obese, and having comorbidities like diabetes, hypertension, or cardiovascular disease. The patients with history of smoking and COPD are also susceptible to having more morbidity and mortality. So as I told you, the incubation period is around 14 days. And then there is a huge spectrum of illnesses. Majority are mild, more than 80% are mild, and only 5% land in critical illness and land in ICU. And so again, these are the common symptoms, which I think you have already seen. In the American Association of Otorhinolaryngology, they have added two major symptoms like anosmia and dysgeusia. So what is the pathophysiology of cardiovascular symptoms? I told you previously, ACE2 receptors, they are used as the entry points for the virus, which is present on the cells of a lot of organs like lungs, heart, kidney, intestines, and of course, my specialty, the vascular system. So Hoffman described this SARS coronavirus, which used ACE2 receptor for the host cell entry, and presence of these ACE2 receptors on multiple organs that potentially explains the patient landing in multi-organ failure. Okay, now the cardiovascular comorbidities are very common in patients with this infection, and the presence of cardiovascular disease is definitely associated with an increased mortality. Cardiovascular disease risk factors and disease, it correlates very well with the increasing age. So again, the Center for Disease Control in China, we have a huge number of cases and 44,000 and odd cases. They have analyzed. You can see here the majority of these patients, 87% of these patients, they fall in this age group, 30 to 80. And a very small percentage are beyond 80 or less than 10.
Yeah, thank you. Okay, back.
Okay. So the cardiovascular comorbidities, they have a 5-fold increase in the mortality. Like if the general mortality is 2%, if they have a cardiovascular morbidities and the corona is infected, their mortality raises to more than 10%. And here you can see the incidence of hypertension, diabetes, and cardiovascular disease, and how the case fatality rate is only 6% with hypertension, 7% with diabetes, but more than 10% if they have a cardiovascular disease. So what are the cardiovascular manifestations? You can divide those cardiovascular manifestations into 5 categories. As Dr. Shivkumar has already told you, myocardial injury and myocarditis causing heart failure, and also acute coronary syndromes, arrhythmias, and of course the last one being the thromboembolic phenomenon, which occurs in both arteries and veins. So I'll just brush through these slides because it has already been dealt with. The direct myocardial injury or myocardial oxygen supply and demand mismatch, of course, is responsible for causing myocardial damage. So this picture effectively tells you how the heart gets injured: a direct viral toxicity, microvascular dysfunction, stress cardiomyopathy, hyperinflammatory state, or which happens in increase in the IL-6 levels, and of course the oxygen supply demand causing type 2 myocardial infarctions, or plaque rupture causing type 1 myocardial infarctions. So this myocardial injury is definitely very important, and it causes a very increased morbidity and mortality, especially in men with older age groups. So what is the early cardiac injury, which is reported in the absence of the respiratory symptom? We have seen a lot of cases with only cardiac symptoms. And here the estimation of IL-6, D-dimer, ferritin, and LDH are very important. The increased levels of these markers in the blood definitely gives us an intimation about how the patient is going to respond and whether he's going to have a fulminant period during his recovery or he is going to die, and all these are going to be gauged by these levels. And this is definitely going to give us the cytokine storm indication. What is the potential etiologies? I told you type 1, type 2 myocardial infarctions, and there are non-ischemic injury to the myocardium, could be due to viral myocarditis itself, or stress, or release of cytokines. So myocarditis, it appears usually after 10 to 15 days of onset of symptoms, and myocarditis may manifest sometimes as a mild chest discomfort or palpitations, or sometimes it can be as severe as a fulminant myocarditis leading to cardiac failure. So in this patient, you can see the normal coronaries, the right coronary, LAD, and circumflex, all are normal, but still the patient had severe myocarditis. So arrhythmias, of course, there are reasons for arrhythmias like hypokalemia or hypocalcemia causing arrhythmias, or myocardial inflammation and myocarditis itself can cause arrhythmias, which can again be fatal. So the coagulopathies, now very important, you can, as it has already been told, the abnormal coagulation mechanisms happens in patients with COVID infection. And the reason for this could be the cytokine storm itself or the inflammation which is happening in the microvascular level. In this situation, there is an increased level of D-dimer, fibrin degradation products, FDPs, and fibrinogen, and there is, of course, a prolonged APTT and PT, that is the activated partial thromboplastin time and the prothrombin time. So in cohort studies, it has already been established that there are thromboembolic complications, at least we can see up to 45% of patients. And that is the reason most of these patients, when they are admitted in ICU, they have been started with a low molecular weight heparin to prevent these thromboembolic episodes. Just to give you an insight into the coagulation pathway, I don't think you will understand this slide, very complicated. And the diagnosis of coagulopathy leading to deep vein thrombosis, or of course, sometimes even thromboembolism causing pulmonary embolism, we have to diagnose these patients using duplex ultrasound. That's the commonest. Just I have mentioned venography, but we are not doing even the CT angiogram. Sometimes for the pulmonary embolism part, we use the CT angiogram, and regular estimation of D-dimer is very, very important to know whether these patients have any thrombotic tendency. So these are the color Doppler pictures. Again, a color Doppler picture, it's an ascending venogram, which indicates that there is a thrombus in the vein. You can see here there is a thrombus in the vein, and the venogram showing DVT, deep vein thrombosis. And of course, the treatment of DVT, previously we used to treat with unfractionated heparin, which was causing a little bit of complications. So we have now moved to treat patients with low molecular weight heparins. It can be either fragmin or clexane or fluxam in these doses. Normally they are given for 10 days, and later on, depending on the symptoms, we can continue the oral tablets, and oral anticoagulation is continued for about 3 to 6 months. So this is a picture which you can see the patient with corona infection and having DVT, who landed up with pulmonary embolism. And many times these pulmonary embolisms can be very, very severe, and it can be fatal, and it can kill the patient. So we should be careful and in diagnosing both DVT and pulmonary embolism. And many times we have to treat majority of the patients who are admitted in ICU with a low molecular weight heparins, which will prevent these thromboembolic episodes. Anyway, thank you very much. I hope I have given you a brief insight into the various aspects of thromboembolic phenomenon and coagulopathies. Thank you very much. Thank you.
Thank you very much, sir, for making the topic very easy and crystal clear.
Thank you.
Any questions? Kindly, we will take it up at the end of the session. Kindly type it in the chat session. Thank you very much, sir.
Yeah, thank you.
We'll move on to the last speaker for today, Dr. Smita. Dr. Smita ma'am is working as an oral pathologist, as a professor in Department of Oral Pathology and Microbiology at Vakaliga Singha Dental College and Hospital. She's also a consultant pathologist for Dental Care and Research Center, Gandhi Bazaar, as well as Rashi Diagnostics at Banaswadi, Bengaluru. She also holds a prestigious editor-in-chief position of our association journal, Journal of Oral and Maxillofacial Pathology, which is an official journal of Indian Association of Oral and Maxillofacial Pathologists. She has held various positions like Honorary Secretary of IDA, Member of Faculty of Dentistry, Member of Board of Studies for Rajiv Gandhi University of Health Sciences. She's also obtained a PhD degree in Oral Pathology and Microbiology under the Dental Faculty from Rajiv Gandhi University of Health Sciences. She is an undergraduate and postgraduate examiners for several universities. She has delivered several lectures at various national and international forums. She's also conducted hands-on workshops and clinical workshops at various forums. She is a recognized postgraduate teacher from Rajiv Gandhi University of Health Sciences. She is an excellent examiner for various universities and also received a prestigious IAMP fellowship. And she has authored as well as co-authored many publications and books. Most importantly, she is the source of inspiration and encourager for many youngsters and beginners like us. Thank you, madam. And over to you, ma'am.
I think she has to unmute.
Can I go about it now? Can you hear?
Yes, ma'am.
Yeah. Thank you for the wonderful introduction, Dr. Deepak, and my colleagues, which is involving Dr. Ranili. I got inspired by Dr. Gururaja in some way or the other, and we always wanted to channelize this further. So that's why we all collaborated and we made this for sure. That is Dawn of Dinosaurs. And it is going into a big forum. I'm very happy for it. Whoever is listening, you will be in for a treat because we are not going to produce anything which is not there in the factual message. So all is it is where evidence message. Next present slide, please. Renalini. Yeah. Coronavirus groups belong to the family of Coronaviridae, which belongs to orthocoronavirus. And there are some alpha coronavirus, also beta coronavirus, which are the two main coronagenera which affects the mammals and humans. Among these, SARS-CoV-2 is the seventh member, which affects the clonal variety, which affects the upper respiratory tract, as well as the MERS2, which affected the atypical pneumonia in the what to call southeast, not even that Arabic area. Next slide. So insight into the genomic aspect tells that SARS-CoV-2 virus has got a 30 kb virus in size protein, and it has got 4 structural proteins among the glycoproteins, and there is a glycoprotein, membrane protein, as well as an membrane protein, and there is ORF means open reading frames, which constitutes some 3A, 6, and 7, 8, and 9 among our proteins. The S protein is required for the host attachment. It provides a lock and key attachment, where the ACE2 inhibitor will be the host, which provides us the lock, and the key will be the receptor, which comes from the coronavirus family. Next slide. Upon entry into the epithelial cells, mainly the cells will be targeting the oropharyngeal cells, then the cells of the lungs, which results in attachment, then integrating into them and releasing them into the cytokine release. So it is named because before that, it's named because WHO virus SARS-2 because it was lethal, and it came in 2020 where the wild epidemic spread out, and the lungs were the primary site, and there were mild like flu symptoms in some people, and there were much more complications where it led to lethal respiratory distress. Next slide. So coming to the oral manifestation, we talk about what is oral cavity constitute. We have the, the label mucosa, we have the heart tissue, which constitutes the teeth, and we have the heart palate, which is constituted by the keratinized mucosa. Some tell that it spreads through the direct droplet which is inhaled through the oral mucosa, and some others. Next slide. Will tell it could be through the eyes or through the nose. But the fact remains that oral cavity is also a main motion of its spread, because it's composed of several hardened anatomical structures like soft tissues, and it is well known for the soft tissue components like lip mucosa, hard palate, soft palate, and it's baked with saliva that is juiciest, and it can attract lots of microbes, including the virus. So you can't tell where it can come from. Directly, it can inhibit the oral mucosa through the fluids or through the soft tissues. Next slide. So a lot of bioinformatics studies have been done where they have tracked down the ACE2 inhibitor and they have located it on the tongue and the buccal mucosa and the gingiva. Yes, these are the soft tissues which are keratinized, and they are the receptors for ACE2 inhibitors along with furin. Furin is an enzyme which is very essential in the oral cavity for the COVID-19 to gain access into the oral cavity. Much evidence-based oral mucosa studies have not been done, wherein you can prove that yes, COVID-19 has been gaining access through COVID, to the tongue and to the furin. But yes, manifestations have been shown. Next slide. Since oral health COVID is affecting many individuals, there is a dilemma whether it's affecting directly or whether it is affecting through systemically because of compromised state. That's the slide which I put in through. Next slide. So I just workably classified into a variable classification where it could be due to nutritional deficiencies, infectious, endocrinology, mucocutaneous, white lesions, and manifestations in the tongue. Next slide. The symptoms which the patient present mainly are related to hypoglycemia. That is, they have difficulty in either swallowing or any difficulty with that, also stomach dryness or chemosensory. That is the altered taste they have. And females have complained made about their having ulcers and some erythematous lesions and facial pains, which we don't know whether it's psychologically related or so in many patients, but it's more so common in females. Next slide. So one of our surveys, which I just took it from one of my good friend, and he did a survey from the National Academic, from the military service from Delhi. And he told that many manifestations were presented and it was scattered on the art palate, tongue and lips. And there was reddish macules and ulcers presented in various forms. Can I show the next slide? This is one of the few slides which I'm projecting. Was mucus pallor was there, angular cheilitis, that is reddishness, and cheilitis means inflammation along the corners of the mouth, atrophic glossitis, where there could be atrophy, means there is baldness of the tongue, and there's some reddishness placed on the tongue, and some of the symptoms, and along the features, there were more presentations of hard palate. Can I show the next slide? All these are our original slides, which we have projected and which I have taken because I have the sincere role to play as an editor of IMP Journal, and I get great opportunity to get the real original slide. Thank you for that. Some people projected with smooth, glossy tongue, deep ambulation of the tongue. So what does angular cheilitis means? Angular stomatitis and inflammation of one or four corners of the mouth. Next slide, which I have already projected. And next slide, where there is an ulcer on the tongue, which we couldn't depict to anything. And this is one of the projections which we recently came across. We just came told that there is mucosal pedicule and hemorrhagic gingivitis and gingival hypertrophy. And this was a recently infected COVID patient which came to us in Kim's clinic. That is our hospital, the VS Redhill College is associated with a medical hospital, which is KIMS Hospital, which is a COVID center. Thank you. Next slide. So I just among the infectious diseases, I wanted to classify among the viral, bacterial, and fungal. And among my experience, I wanted to tell a few things. Like we came across herpetic gingival stomatitis, and one of our own oral pathologist, who's a wing commander in Delhi right now, is posted. He presented his case and he wrote a letter to the editor, which I published recently in JMRP, where he had herpetic, not even labialis or something, which was something to do with what to tell, herpetic chickenpox, which is shingles, which is a universal presentation, which I'll show you in the next presentation slide. This is the small herpetic or hepangioma-like presentation. Next slide, please. There is a herpes gingivalis labialis, where the people present with labial ulcers. Next slide. Gingiva and the oral mucosa is more involved, and vesicles are there, and it is much more painful, and they coalesce to form large bullous lesions which ulcerate, and they tend to form erythema mucosa. Next slide. This is one of the clinical presentation which was published in the recent journal of JOMFP, which was by our own oral pathologist, who is a wing commander, who is now posted in Delhi, who himself suffered from corona, and he presented his own manifestations. I've just put up the slide. You can go and refer back to his referral. It's come up in our latest issue of JMFP in 2019. Thank you. So some people have also presented and written letters to us about how they're presented with. It's like hepangioma, which could be affected by Coxsackie, but it's not proven. There is involvement of oral mucosa pharynx and also the oropharynx, where the uvula is also involved. This is a diagrammatic representation of the same. Next slide. Bacterial. This is a much more skeptical thing, which I'm worrying about, because many people, surgeons especially, they're coming up with what to tell, deep dental caries and presenting with osteomyelitis. And they don't want to group under which one, but they have all presented with chronic osteomyelitis. And the jaw, either the maxilla or the mandible is coming out, and we are not able to trace the particular organism because we don't have the sophisticated mechanism, I believe. But we are just able to tell them that there is a spectrum of microorganisms in the histopathology. We're not able to pinpoint whether it is fungal or bacterial. So there are also, when you see the soft tissue, we can see some obliteration of the vessels and hemorrhage, but nothing other than that which will be conspicuous or which will be elaborate to tell that it's a related to COVID. It's a superinfection infection. Candidiasis, yes, definitely many patients are presenting with that. We can see the pseudomembranous stripe. Next slide. Which you can see this form. Next slide. Yes, erythematous also we are able to see flat multiple type. Next. Leukoplakia. Many people who are smoking and who have been not associated with coming to the college or showing their inspection have also developed many various forms of complications. Can you show the next slide? Angular cheilitis is the most commonest form. We don't know whether it's associated with candida or some deficiency, but it's a common problem. These are all original pictures. Endocrinal, definitely with the diabetes mellitus. Poor origin has left to oral periodontal abscess. Next slide. We have come across this in our scenario. I would like to show this and profound. And there's also dental caries, which is aggravated by some white pedicle macules or some sort of rashes which they complain, which we think it could be related to stress. Yes. Autoimmune, we are not able to pinpoint on that, but there's definitely decreased saliva and there is definitely dry mouth associated with these patients. But it's a short period for us to estimate and pinpoint on that and to give a diagnosis. Now coming to the three major scenarios, which is periodontal disease, dental caries, and leukoplakia and precancer. Periodontal disease, I would just like to change to the next slide. There's elevated number of chemokines which are released because of the destruction of the periodontal ligament. Next slide. The immune cells mainly are monocytes and also the lymphocytes, which will contribute for the cytokines. Next slide. This is a depiction of the same where you get the characters such as interneurons, interleukins, and also TGF-beta. Yes. These are all increased in periodontal status, and the next sequel which I'm going to talk about is dental caries, where dental caries sequel is leading to, because untreated dental caries among the adult population is leading to osteomyelitis. Next. And I don't know what is contributing for that, but we have come across 3 cases of osteomyelitis. This is affected 2 cases in the mandible and 1 case in the maxilla, where there's no other cause other than chronic dental caries. Next slide. So we are attributing this to only the dental caries, and profounding to that is the use of what to tell steroids and such stuff, because we are not even able to demonstrate any autoimmune or any microbes or fungal organisms attributing to osteomyelitis, but we have reported that. Thank you. Next. Yeah. So I would like to conclude that COVID-19 leads to a lot of manifestations, including drug eruptions, dysgeusia, xerostomia, and also it leads to ulcerations and also gingivitis. Next slide. Among pre-tobacco and tobacco users, because of prolonged usage and because of them not showing to us, it could have led to complications. We're not aware why it has led to complications, but whatever cases have been reported to us till now, it has been hazardous. They're not able to even come with a rectifiable notage for them. Thank you. And these are some of the manifestations. These are originals. Thank you. Yeah, all these have led to much more complications. We are unable to help them. All these have been diagnosed with multiple, either with salivary gland or with SSC. In summary, I would like to tell that dysgeusia, petechiae, candidiasis, traumatic ulcers, and herpetic infections among candidiasis are more common. Next. These are some of the symptomatic presentation orally, where you can see diagrammatically or pictorially. So it's very important for interdisciplinary as well as the dentist perspective and relevance, because we also play a pivotal role in the hospital setup. Next. Since there is a vivid presentation like coming from a vibroma or from a scrotal trunk, anything can do with COVID because it's an immunocompromised status. I just wanted to highlight in this perspective that what we can play a role, and we had to be in the stream or trading among all the doctors. Thank you. These are my references. These are my general but my students have helped me a lot. I owe them a lot. Thank you.
Thank you so much, ma'am, for those compiling the data of oral manifestations for COVID in the oral cavity. Thanks for in detailed presentation. Now the forum is open for questions. Dr. Gururaja sir will take over as a moderator. Is there any questions from the participants on all these 4 topics?
Hello. Can you hear me?
Yes, sir.
Yeah. Thank you very much, all the speakers, Dr. Suma Nagesh, Dr. Shiv Kumar, Dr. Muralidhar, and Dr. Smita. Interestingly, we had a very good session for about 1.5 hours or so, and we could gather a lot of information regarding the various changes that take place in the whole body, whether it is heart, whether it is oral cavity, whether it is lungs, or whether it is blood vessels. Okay, and incidentally, all these are associated with the viral loads that is existing as a result of COVID-19. The whole premises of COVID-19 starts with the involvement of the viral organisms into the body, and that too through the ACE2 inhibitors that have opened the gateway to into the body through epithelium. And when it goes to either alveolar mucosa or oral mucosa, or it can even cause the clogging of the blood vessels, which could lead to even embolism, and that could lead to a severe amount of heart problems, which could be in the form of myocardial infarction, or it could be as a result of acute respiratory distress syndrome, and can lead to all sorts of problems. In fact, oral cavity has been the gateway for all these conditions. And you know that very well, the saliva plays a very important role in the viral load shedding also. And incidentally, the dentists have to be very cautious when they are trying to treat such patients. Incidentally, the oral cavity does manifest the acute ulcerations of the mouth, the Kawasaki's disease, which probably has not been mentioned. The cytokine storm can also bring about a variety of changes in the tissue resistance, and that can bring about associated fungal infection or viral infection or bacterial infection, which can even bring about not only ulceration of the oral mucosa, but also osteonecrosis too, as a matter of fact. And you can see the bare bone also, which is denuded of oral mucosa in many situations. Incidentally, we have made a lot of information regarding how the various changes that take place in the body, and we attribute thanks to all the speakers who have done a great job in giving us a complete scenario of the changes that take place in the lungs, in the heart, as well as the oral cavity. Thank you very much. I request the organizers to take over the podium for giving certificates as well. Yeah. Deepak and Mrinalini.
Thank you, sir. I will request Dr. Mrinalini to hand over the certificates to Gururaja, sir.
May I request the first certificate to be handed over to our chief guest, this is to Dr. Smita, who has participated and given a lecture. Dr. Smita, God bless you. Thank you for the same.
Thank you, sir, for your immense,
welcome,
lovable gesture, and also encouraging for achieving more and more sites. Thank you.
Thank you. Thank you very much. The next certificate will go to Dr. Muralidhar, the E-certificate.
Thank you.
Thank you, Dr. Muralidhar. You have been the backbone for this program.
Thank you.
Incidentally, you are the one who had organized, I will say, and took up the lead for even providing the link also. So thank you very much. This is a great event, and I hope people have learned lessons from COVID-19 and its impact upon heart and the vascular system. Thank you very much, Doctor.
Thank you, sir. Thank you very much.
The next, our guest of honor, Professor M.K. Ramesh, who happens to be the great man now heading in the National Medical Commission as the president, and he is a great person who has been a support to us and who has come and inaugurated this program. Sir, we acknowledge your presence and your participation. Please accept our humble e-certificate on this regard. Thank you, sir, for your attendance. God bless you. Next. Dr. Shiv Kumar, I am very much happy to see your lecture on the cardiovascular as well as the heart changes. And indeed, we have learned a lot of things from you. Thank you very much for your attendance and your participation as a speaker for this event. Sir, thank you very much. This is your e-certificate. Thank you very much, sir. Okay. Yeah. Next. Yeah, Dr. Suma Nagesh, we have been very much happy to see your opening innings, which you took over as a physician to describe elaborately the various changes that take place in the heart, lungs related to the COVID-19. Incidentally, you have given a very nice pictorial description of COVID-19 and its impact upon the heart. Madam, this is your e-certificate. Thank you for participation. God bless you. Thank you. So at the end of this program, may I request Dr. Deepak to give a vote of thanks.
Rinaldi?
Yeah, anyone, Rinaldi or
Rinaldi will be delivering the vote of thanks.
Yeah, please.
Yes, it was indeed a very great and special evening with our brains completely loaded with immense and valuable information. And I would love to thank Dr. Ramesh sir for your valuable time and your online presence and your encouraging words to our group. Thank you very much, sir. And now I would like to thank all our valuable speakers, our COVID warriors, Dr. Suma Nagesh ma'am, Dr. Shivkumar sir, Dr. Muralidhar sir, and Dr. Smita ma'am for your valuable time and sharing and enlightening us with not so known facts. Thank you again. And we would also love and like to thank our moderator, Dr. Gururaja sir, and he's the main force behind each webinar of its kind. And thank you, sir, for you are the secret of energy of this group, like Boost. Thank you so much, sir. And I would also like to thank Dr. Deepak for your valuable inputs and co-hosting the webinar. And we would also love to thank all the participants across and we all had a great evening and we all imbibed a great deal of information today. Until we meet till the next webinar, stay safe. Thank you again. Good night.
God bless you all. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you.
Lovely to interact
Thank
with
you,
all of
everyone.
you.
Thank you, everyone. It was very nice.
Thank you. It was very nice. Thank you.
Thank you.
Thank you, sir.
The e-certificates may be posted to the email ID.
Yes, sir, I'll do that. Don't worry.
And
I'll do that. It's
Ramesh's e-certificate, if you send to me, I can send it to him. No problem.
Sir, we'll do all that.
Thank you.
Our
I know.
graciousness.
It will be a nice gesture from your side. Thank you very much.
Thank you, all of you. Bye.
Yeah, I will end the program. No problem.
Yes, sir. Thank you for your lending your support. Thank you a lot.
Thank you.
Thank you.